Good afternoon, everyone, and welcome to The Upside. I'm Jonathan Oleski, and this is our virtual show brought to you by the Associated Jewish Federation of Baltimore and JMOR Magazine to keep Jewish Baltimore informed during this time of uncertainty. If you have questions for today's guests, please type them into the Zoom chat during the show. Now, it is my pleasure to introduce our fabulous hosts, Beth Goldsmith, Chair of the Associated Jewish Federation of Baltimore, and Dr. Scott Rifkin, publisher of JMOR. Beth, go ahead and take it away.
Thanks, Jonathan, and welcome everyone. In mid-December, healthcare workers and nursing home residents began receiving their first doses of COVID-19 vaccine, offering us all a sense of hope in this year-long battle against the pandemic. As of yesterday, nearly 9 million Americans have been vaccinated. Yet, with many states still in phase 1A of vaccination, we have a long, long way to go to reach immunity. At the same time, we are hearing of healthcare workers in some parts of the country who are actually refusing to get vaccinated, citing safety concerns. So on today's Upside, we're going to talk about the vaccine, how safe it is, and what we should expect in the coming months.
Beth, I'm going to go ahead and introduce our guest today as we're waiting for Dr. Rifkin to join us, who's detained by another meeting. But, as they say, the show must go on. So today we are very excited to welcome Dr. Wilbur Chen, professor of medicine at the University of Maryland School of Medicine and chief of the Adult Clinical Studies section for the Center for Vaccine Development and Global Health. Dr. Chen, thank you so much for joining us.
Well, thank you for inviting me.
You bet. So Beth, I'm going to go ahead and kick it back to you, and then we'll go back and forth with questions for Dr. Chen today.
Great. Thanks so much, Jonathan. So I guess we'll start at the beginning. Tell us about your work in relation to the COVID-19 vaccine.
Well, normally when there's not COVID, I have spent my career developing vaccines, and most of the vaccines that we're developing are for low and middle income countries. So I concentrate on diarrheal diseases. So these are pathogens because there isn't safe water or sanitation and hygiene that exists in many of these areas that are resource poor. And we also try to develop malaria vaccines, dengue, and other things. But when COVID came up, we were in a pretty good position to respond because we were one of the centers that has been responding even over the past just 10 years to a number of situations. So I was the principal investigator of the national H1N1 2009 pandemic vaccine studies through the NIH. And then we were the site that initiated the phase 1 studies for the Ebola vaccine and for the Zika vaccine. And our affiliate, which we directly manage in West Africa, in the country Mali, was the site that implemented the first Ebola vaccine when Ebola broke out in West Africa in 2014. So again, we've been pre-positioned to respond in a number of different ways. We have active research on a number of different agents. And again, that allows us to be rather acquainted with a lot of these pathogens so that we can then be able to use that kind of background expertise to something novel like COVID.
Dr. Chen, could you just help us in layman's terms kind of understand how these various vaccines work in protecting us against COVID-19?
Yeah, I certainly would love to explain in plain language. Any vaccine that we use, it can be a purified protein vaccine. It can be a modified and weakened viral vaccine, which is a viral vectored vaccine, as an example. There are a number of different ways that we can make a vaccine, but all it comes down to is that you're putting down into that injection, or if it's a pill that you swallow, some vaccines are swallowable, even pediatric vaccines, or even squirt up the nose like the flu mist. They're all introducing pieces of that germ that you're trying to protect against and trying to inform the immune system to be able to recognize it so that the next time it actually sees the real thing, it can mount an adequate defense against it. So a lot of what we talk about is antibody response, and that's one of the proteins that the body can make in the blood that can fight off infection, and that's measurable. When we get a blood sample, we can measure a titer, to see if we've been vaccinated previously with hepatitis B vaccine and look at a titer to see if it's still there, or a measles titer, to see if we have measles vaccination in the past. So those are all kind of measures that we can look at, again, from the immune response to show that we've been either vaccinated or maybe had the actual infection in the past, which is why antibody studies, that you hear about for COVID are, again, informative because it helps us to know whether or not you had that infection. And some people have asymptomatic infection or mild infection such that they didn't know that they had the infection. So that's all kind of informative to that immune response.
Wonderful. And Beth, I see Scott here. Scott, I'm going to step back and let you move forward with Beth.
So Dr. Chen, my apologies for being late, but you'll appreciate why I'm late. I actually was getting my vaccine as we speak, and I got delayed longer. They wanted to watch me for a little period of time afterwards, and that whole thing. What amazes me is how easy it was, how safe it was, how routine it was, and how many people are still refusing to get it. The nursing home where I received it, because I'm on the staff and I'm a physician, 60% of the staff said no. 60%. Almost 100% of the patients said yes, but I'm not so sure 90-year-olds with chronic disease are going to get the most benefit out of it, and I'd love to ask you about that. But talk about the safety of the vaccine in general.
Yeah, that's a great question, and I get a lot of these questions. And I think let's just back up and talk about why is there so much hesitancy. And some of it is because of misinformation out there. And in fact, in the internet age, there's so much information out there, and people are unable to discriminate between what is actually false versus what is true more and more, because you can do an internet search and people don't know, but most of the time false information comes up or misinformation. So a lot of that builds into it. There's also been an erosion of trust, unfortunately, for both physicians, but even for government, for the CDC, which has long been held to be a place where again, truth comes from. So, again, there's a lot of mistrust out there, erosion of trust that builds into that misinformation as well. And then, of course, there are pockets of the population, very important, communities of color who have experienced the highest burden of the disease, but also have historically experienced, the fallacies of badly performed biomedical research, or other things as well. So again, that builds into a mistrust in the population. So again, when I hear that 60% refusal rate for persons who are providing care at the nursing home, it saddens me. But of course, I can understand it to a certain level because there has been a lot of misinformation out there, a lot of erosion of trust, and those other things that I mentioned. Okay, so that's just that. Let's go to the safety. So, when we develop any vaccine or therapeutic, we have to undergo a number of steps along the way for it to be approved by the FDA. And the FDA has not removed any of those steps. So we continue to maintain the integrity of the review and approval of vaccines from the FDA, which means that as we are developing these COVID vaccines, we are developing them at remarkable speeds, but it's not that we're skipping any of these procedures. So we continue to have to provide the data to the FDA on the so-called safety and the efficacy of these vaccines. And the so-called safety, I say that because, as a scientist, when we try to say something as a statement, we like to be backed up by evidence. We like to also kind of be rather definitive, which is, again, when you say, if you're driving in a car, are you safe or not? And I, as a scientist, will say, well, if you wear your seatbelt, if you this or that, that's safer. But is it 100% safe? No, because you can always get into an accident. You can always step off the curb and get hit by a car crossing the street, even if you're using a crosswalk. So again, is that safe? You know, that's up to interpretation, but it's not 100%. Nothing in life is 100%, unfortunately. So this is a situation where vaccines are relatively safe, and we have proven it by the clinical trials that we have done. What that means is that we have many tens of thousands of people who have been evaluated in these studies before they are EUA approved to give us that safety information. So where are the holes? What does that mean for the safety that we don't know? So that's the other hand where maybe it gives you perspective as to why I can't say 100% safe these vaccines, is because I can't answer to you if there is a rare adverse effect that happens in 1 in a million people, because we haven't studied the vaccine in millions and millions of people. Now we've started rolling it out so that we have 9 million people. So now we can actually start looking at those rarer things, but it's not until we have had it approved and start using it. Okay, so we can't, before the approval process, say whether or not it has a rare adverse effect to the order of where it's so rare, it's 1 in a million.
But Dr. Chen, isn't that the same as when we give a flu vaccine as well?
Well, for flu vaccine, we have had many decades of experience and many hundreds of millions of people who have received it over those many decades. So that's it's billions of doses, in fact. And so we can, with more precision, you know, as a statistician from that perspective. So I think, again, we can say safe, but we can also we also want to be transparent, because I don't want to come across as flippant either, so that when we develop these vaccines so quickly, that when we start seeing those anaphylaxis events, which are now, it looks like it's about 1 in 10,000 people that are getting vaccinated that have anaphylaxis. That is a little bit, is it 1 in 10,000? Yeah, I think it's about 1 in 10,000 is the statistic. You know, it's about 10 times more common to have anaphylaxis due to COVID vaccination than due to the flu vaccine, okay? But it's also 10 times less common than the anaphylaxis events after a penicillin shot. So that gives you a perspective. But we wouldn't have that data until we have more of that data and we have more people that are being, you know, vaccinated. So I can only give you that perspective over the past week because the CDC just published those results. I couldn't have told you that shortly after the vaccine was approved before we started using it.
Scott, let me jump in with even another little controversy, and that is that we hear a lot of talk about releasing almost all of the vaccine that's currently available so that as many people as possible can get a first dose, versus the original thought of holding back half of the vaccine production to ensure a second dose. So will you speak a little to the efficacy, what happens if that second vaccine isn't available, and what going beyond the recommended time frames, you know, what that might mean?
Yeah, for the 2 vaccines that are approved right now, if you get 2 doses, we know with really good data that it's about 95% efficacy, which is terrific, just absolutely terrific. Now with the 1 dose, we have very little data, but with the little data, it looks like it's maybe about 70 to 80% efficacy, which is not too bad, but I can't really say as a scientist how good that number stands by itself, because there's what we call confidence intervals. So you know, it may actually be more like 50% or what have you. But anyway, so that's still a very good efficacy with 1 dose. Now, I can't tell you how long that lasts, because the studies that we looked at, you know, where we have that data, really is that time frame in between that first dose and that second dose. So I don't know if that 80% is a real number, maybe closer to 50%, let's say, but it also may not stand for how long it is. So maybe it only is 80% for a month, and then it drops off significantly unless you get that second dose. So to me as a scientist, I like to be data driven. This is why I kind of am pedantic in that way, and sorry to say it this way, but I really try to be transparent and truthful as much as to the population when I communicate these things, is that I don't know if that's the best way to go about implementing our national vaccination, because I don't know if that protection will last that long. So that if we delay that second dose to the population out to 12 weeks, which is what the UK is doing, 3 months, 6 months, it may be that that efficacy drops off significantly after that first month or that second month or whatever. And then it may be that such that it's almost like they didn't get vaccinated shortly after vaccination, after 2 months. And so again, that may not help people, who are really banking on being protected after that first dose. So, so again, that without more data, I can't really say whether or not that's a great strategy. Now, what I can say is, why is this strategy being actually considered? There are a number of different considerations that you might want to do it. And again, if the bottleneck is simply the number of doses that we have right now available, and we can immunize people, we want to immunize more people, then that would be maybe the strategy and the way to go, to immunize more of the population and get some protection. Now, I'm boots on the ground with my medical center. And so the University of Maryland Medical System has 13 different hospitals. And we, in fact, the bottleneck is actually being able to give, X number of doses. And we're trying to give 1,000 doses per hospital per day. And that's been difficult, because even though Dr. Rifkin just described how pleasant it was to get vaccinated because it was so organized, it actually takes a lot of logistical work to get a vaccine clinic up and running. And so you have to have the right PPE, you have to have the right appointments that are being made beforehand, during, and after. You have to have a consent process, which a lot of us are using electronic consent, but it has to be sent to you. You have to sign off on it. We have to confirm who you are when you come in and make your appointment for your next dose. We have to document, which dose you got. This is all reported to the state as a mandate. And the mandate is that the state has to report back to the CDC, to the national level. So a lot of this is an IT infrastructure that has to be built in the background of every single vaccine clinic. So you can imagine, yes, it would be easy for us to send out vaccinators, even to go to homes and vaccinate in homes, but you still have to have the IT infrastructure for that person to verify who it is in the population that they're vaccinating, and making sure that they enter which dose that they're getting and when, and be able to make the appointment system for the next dose. So it's a little bit more complicated, which is, vaccine clinics, good vaccine clinics make it look seamless, but it requires a lot of work in the background to get it set up and have it up and running with each day. So that's kind of, again, the bottleneck is not necessarily the number of doses that are actually available and released in the state or in the county. It's actually being able to have the staff and the buildup and the training and all the infrastructure to actually have a clinic that can give 1,000 doses in a day, or whatever it is that your target is. We're trying to build up to that, but right now it requires a lot of training and infrastructure that we're continuing to build up.
So, Dr. Chan, I completely agree with what you've just said, but I want to get back to the issue of reluctance.
Yeah.
Because I'm confident that the system will figure out the logistics. Then it comes down to people being willing to take it. And and you went through the science behind what advice we can give people on the safety of the vaccine. But the other question really is, what's the safety of the vaccine versus the safety of not taking the vaccine? In other words, if you don't take it and you catch the virus, and it's very contagious, and the likelihood eventually that virtually everybody will catch it is, I would think, is pretty high.
Yep.
What is
so I think
the trade-off there? Because that's really the question we're asking people to decide.
And that's exactly right. That's what I try to describe to everybody. What is the benefit versus what is the harm, right, of that decision making of either to get vaccinated and not get vaccinated, or any other decision that you make in medical practice, or if you're deciding whether or not to get a knee operation. So okay, the harm in getting vaccinated is that you would potentially get a sore arm, maybe feel feverish, achy, those sorts of things. Some people feel it mildly, some people don't have it at all, some people feel it more profoundly, and some people feel bad enough that they want to call out for a day or two. But all of it self-resolves and is temporary, and goes away within 3 days maximum. is the duration. So that's kind of the expectation. Now, there are those rare side effects of the anaphylaxis that I told you about, a rare, but something that we look for in the vaccine clinic and we manage immediately and treat. And so it's completely treatable. And so those are the major ones. Now, you might have heard of Bell's palsy, which is kind of this transient facial paralysis that people can have, but they can also have it after a natural viral infection. It's been seen after flu vaccine and other vaccines, and we don't know if it's actually related or not to COVID vaccine, but we've heard of a few cases of that. So you might have heard that. Okay, so those are the major safety considerations to get vaccinated. Now, what's the consideration for not getting vaccinated, as Dr. Rifkin was saying? Well, first of all, if you got the infection, which is highly likely if you don't get vaccinated and you get exposed, you could have mild disease, which might just be something like the common cold and may not get worse. Okay, that would be a great situation, but you would still probably be required to quarantine and self-isolate. So for those people whose occupation requires them, they don't have the ability to telework, they're in construction, they're in manning a grocery store or other thing, they may also not have days off where, again, if they're not working, they're not bringing in money. So they don't have that luxury of getting ill, even mild illness, where they have to take off those number of days for isolation. That is not a good option. Now, if they get more severe infection, they may become to the point where they have to be hospitalized. That's also going to cost something. Now, it could cost your insurance or something else, but it is certainly detrimental to your health. You could die. You could have some of these other long-lasting medical complications, such as a stroke, a heart attack. And then some people have loss of taste, which actually, for some people, it sounds like it's getting to be permanent. I mean, people are out there for many months now, 6 months without taste or smell. And that is one of the things that we have seen so far. We've also seen loss of hair. So again, that's not something to laugh at, because again, that's a cosmetic reality. Then there are the long haulers. So again, there are these long lasting symptoms that could be very profound lethargy, kind of cognitive defects where basically people can't concentrate, they don't feel right, mood dysfunction, and other things, again, that are very long lasting, that are detrimental to people's quality of life. Again, that could be with mild disease. And then some people feel short of breath and other things. So there's a laundry list of things that I've just described, and it could be the spectrum of any of those. So that's what you're weighing against when you're deciding whether or not to get vaccinated. I don't
Dr.
know if that
Chen?
addressed it, Dr. Rifkin, but that was a good question.
No, that's great. So you're an expert, and I want to make a point because a couple thousand people are going to watch this on Facebook and elsewhere, and you're an expert, and that who keeps up on the science. And what I hear from people is, I haven't done my research yet. I'm always amazed by folks who think that they know better and they can research better than experts like yourself. So you're an expert. Did you take the vaccine, A? And B, do you recommend it to your patients and to your family members?
Absolutely. I got vaccinated, and this is why I got vaccinated. Hopefully you can read that. I don't know if it's going backwards or forwards on your
Oh,
screen.
it's right. It's right.
Okay, because on my screen it looks backwards, but these are the reasons why I got vaccinated, and I get my second dose on Inauguration Day, so that's going to be a terrific day for me to get my second dose. But again, and as soon as my children and my wife are eligible to get vaccinated, absolutely, I will make sure that they get vaccinated, and all the people around me, my neighbors, my friends, my family, my older mom, who's 82 right now, and she's wondering exactly when, and she thinks that I have an inside knowledge as to when those vaccines will be available. And it's really up to Governor Hogan, which, he'll have a press conference today, and so he may announce it today or sometime this week, but I don't have foreknowledge of that. But again, yes, I am certainly a vaccine champion.
So
Thanks. And I want to, Scott, I'm going to jump in again. So, because so far, Scott, the only side effect you have is it made you disappear. But
yes, I apologize. And I really do apologize to everybody.
I know it's okay. Minute. I'm sorry. I couldn't resist that joke. But,
no.
But I think it's important that it's important that we get people to understand also. So Dr. Chen, after you get your vaccine, are there still protocols you should be following? Social distancing, masking, for instance. So even if you've had both vaccines, even if you've had your first and second dose, would you speak to what that really means? Is there a change in your daily routine?
Yeah. So, even though you get vaccinated, with the 2 doses even, and that get that 95% efficacy, 95% is still a 1 in 20 chance that you don't get protection, full protection. Now, that doesn't mean that that's not effective. I mean, so if you don't get full protection, maybe that prevented you from being hospitalized or die, but you just have mild sniffles. So that's highly effective to me still. But that efficacy that we say that 95%, that's what it really means, is that we're trying to prevent, certain outcomes of measure. Okay. So, that is really what I'm speaking to as to why these vaccines are valuable, but we still don't know whether or not it will block you from transmitting to other people. So even if you're vaccinated, I still would want people to adhere to universal masking, the hand hygiene, washing your hands, those sorts of things, physical distancing, until the majority of our population has gotten vaccinated, then we can really open up. But at this time, people, when you walk out there in public, they don't know if you've been vaccinated or not. And so again, if we're walking around without masks and we're not, we're crowding people and those sorts of things, we don't know if they've been vaccinated. And so again, we don't want to give that message that we don't care about other people around us. In fact, you care because you got vaccinated. So we want to continue to demonstrate that we care about the people around us, and also acknowledge that we could be, in fact, asymptomatically infected and potentially could transmit. So again, for Dr. Rifkin, he'll continue to have to observe, PPE, the masking, the gloving, and those sorts of things while seeing patients, because he really won't know 100% whether or not he is infected and could transmit it to one of his older adult patients that, again, could have a detrimental outcome with an infection. So until we have, again, more of the population that is, and we see basically, you see the statistics for our county or our state kind of plummeting down, that's when you really will know that the vaccine is really working well, because we've gotten most of our population vaccinated. And of course, as cases decline, the risk of transmission declines tremendously.
Dr. Chen?
I'm a much better looking guy with a mask on, so I may wear it permanently, Dr. Chen.
Okay.
So,
Oh, funny.
Jonathan, you had a question?
Yeah, I'm going to jump in because Dr. Chen, we have a Facebook question from a listener, Hillary, who asks, if 2 people are fully vaccinated 2 weeks after the second dose, is it safe for them to be around each other again?
I think that yes, if you are meeting in private groups where, again, you're cocooning yourself and doing safe practices, then I think that yes, you can, is the answer. So 2 people who know that they've been vaccinated, they've been fully vaccinated with the 2 doses, they've waited for the obligatory 2 weeks even after those second doses. I think that those 2 can meet together. But again, when they're out in public, again, I think that they need to maintain that posture again. I think, again, part of it is just sending that positive message that, again, there's nothing wrong with masking. In Asia, masking has been a popular thing anyways, just because of smog and other things as well. But again, so I think that there's nothing inherently wrong with being out there and masking or whatever. It is not comfortable in certain situations, especially the summer. So hopefully we'll be better off in the summer. But again, hopefully that answers that question. But I still want to encourage people to mask and observe hygiene when out in public.
Great, thank you. Beth, Scott?
Yeah, I was going to ask about children. I know the vaccines have not yet been approved for, I think, anyone under 16. Could you give us a little insight to that and when that may change?
Yeah. Well, it's not because we don't want to vaccinate children. I think it's because we just haven't had the time to do those studies. So the first, priority was, of course, to make sure we vaccinated adults, and especially the adults that are at highest risk for getting severe disease. So that's making sure we show that the vaccines are effective against older adults. And going back to Dr. Rifkin, he asked what's the efficacy for older adults. And actually, in the studies, when we looked at older adults versus the younger adults, and even by decade, 85 and over, 75 and older to 85, that the vaccine's efficacy continued to hold out, so it didn't drop off tremendously. So I think we still look at 90% plus efficacy even among older adults, which is terrific. Okay, so going back to children. So those studies are being done right now. We're trying to develop the data to substantiate so that the FDA can really give that approval. There's really no scientific reason why these vaccines won't be effective. It could be that they're more reactogenic in children, so maybe we have to go down in the dose. Again, that would be the consideration, is that maybe, the same adult dose, just like some other vaccines that we have, the pediatric dose is sometimes a half dose or a quarter dose of what the adult dose is. And some, amount, may be, for a smaller child especially, maybe, more reactions. And so we don't want to, if we can help it and still have intact efficacy, if we can have less fever and less pain for the child, obviously we would like to have these vaccines highly acceptable as much as possible in our control. We also have to work against, trying to do all of these studies and taking a long time before we can actually roll these vaccines out to children. Because to me, I think the preschool and K through 12 age groups, we want to get them back to preschool and back to school in person as fast as possible, and vaccinating this part of the population is such an important part of that. So it's very much a high priority in my mind to be able to move toward children's vaccination, especially looks like it's probably not going to be available for the spring, but hopefully we'll have it available so that by fall we can have in-class education across the board. So that would be my kind of goal and my aspiration. So that's kind of what I think is happening for the pediatric population.
Thank you.
Very good. So are there any groups that shouldn't get the vaccine? I want to make that clear as well as also.
Yeah, so really the only contraindication that we've found so far, and this is about 9 million doses now that we've seen, is really the people who have demonstrated anaphylaxis to one of the known ingredients in the vaccine. And the ingredients, honestly, are these, really long scientific names, so I wouldn't expect people would know. One of them being that pegylated glycol, PEG, and so that is an ingredient, again, that people wouldn't know. So, again, people are getting vaccinated and having some anaphylaxis after that first dose, so they will be ineligible for getting that second dose. But realistically,
it's not the eggs. Talk about eggs.
There's no eggs. There's no eggs or anything in the vaccines, in the mRNA-based vaccine. So nope, it's not a problem. So even with bee sting allergy anaphylaxis or some of these other histories, they are still eligible to get vaccinated. We watch people very closely if they have anaphylaxis. So that means anyone who has an allergy and carries an EpiPen as a normal part of their life, like a peanut allergy or whatever, those are people that we instruct after vaccination to be observed for 30 minutes after vaccination, just in case they develop those anaphylaxis type of reactions. And then we manage them, with an EpiPen, with steroids, and we monitor them very closely until they get over it. And then if they do have it, then we basically say, okay, well, you've declared yourself that you have a bad reaction, anaphylaxis, we're not going to give you the second dose. So that's the only contraindication at this point. So immune suppressed people, cancer, people who had transplants, people who have diabetes, heart disease, lung disease, kidney disease, all eligible. Upper ages, eligible. So again, that's the only contraindication to vaccine right now.
Very good. Very, very helpful. Very helpful. Beth, questions?
Yeah, I guess this is something that I'm curious about. If you've had COVID, for those people who have had it, whether a severe or a mild case, I mean, we've had experts on before, and if you've only had a mild case, perhaps your antibodies aren't as strong. Should you still be getting the vaccine? How does that work?
Yeah. So we are still encouraging people who have had COVID infection to get vaccinated. And in fact, you may have been infected and you didn't even know. So one of these asymptomatic people, and not everyone gets tested. And so you might have even gotten tested, but you got it tested well after you got the infection. So you had such a mild infection that you didn't know that you should get tested, or you had no symptoms at all. Again, those people had the infection and didn't even know it. They should be getting vaccinated as well. So people who got infection and knew it, let's say they had symptomatic disease and tested positive, they still should get it. Now, people who know that they had the infection are instructed that they may delay their vaccination to allow other people who haven't gotten vaccinated to go ahead of them. So prioritization is really what we're talking about. So, but a lot of people in fact don't know that they've been recently infected or what have you. So, people say, and we're saying, if you know that you've been vaccinated, you again are instructed you may wait for 90 days, but after those 90 days, you should get vaccinated. But you don't have to wait for the full 90 days. So you can just wait, um, you know, uh, 30 days if you want to, or not wait at all, I suppose. But again, this is really just trying to, again, give the local health authorities flexibility in trying to prioritize the vaccinations for the population. So if they know some of their people that they're vaccinating had recent infections, they'll say, okay, well, why don't you wait until next week? Because we've got a lot of people in our waiting list right now. We're going to try to get through them, and then we'll have you hold back. You've had the infection already, known infection, so you should be protected for that at least short period of time. And so, some people can, again, it's safe to wait for 90 days. So it's not that they're not getting vaccinated, it's just basically they're being deprioritized. So that's the message that you may hear from your local health authority. And they are allowed to use that in a flexible manner where if they've got, no waiting list, get vaccinated. But if they've got a waiting list, you're going to be deprioritized. And so don't be surprised by that. So for your listening audience, from state to state, there's been a very different implementation. So you're probably hearing, why is it that Florida, we're hearing about that it's almost like a free-for-all because they almost opened up the doors and anyone can get vaccinated, right? So that's kind of what's happening on the implementation level. Maybe it's been difficult for them to kind of control and implement. Here in Maryland, we've been very strict with how we're opening up the phases, and it's been very controlled in how we're implementing vaccination. But again, I can't speak for every state, but each state is given local jurisdiction in how they're implementing the vaccinations. It's not mandated by the federal government. The federal government gives guidelines, and those are kind of basically, this is how we would like it to be optimally followed, but you're given the ability to flexibly implement it because again, every state is different. So hopefully that describes that, but there is a lot of mixed messaging even around implementation. Why is it that my cousin, in X state was able to get the vaccine and they are only 40 years old and have no comorbidities, and I'm 72 and I should be vaccinated, but I haven't been able to get vaccine yet, and I live in this other state? So again, that's why, because a lot of states and jurisdictions are implementing these vaccines very, very differently. And that's kind of, again, a lot of the confusion out there.
Yeah, I'm in Florida. It is a
Okay.
free for all. I mean, no,
Unfortunately.
I haven't been able to get mine, although people keep telling me they've gotten them. But the county where, unless I would drive, people are driving many hours to counties where they are making
Yeah.
appointments. Where I
Even
am,
within the state,
where
it's
I am,
very
you have to
variable for
check
the
in.
county.
Yeah, where I am, you have to check in every day.
Yeah.
And to see if there are any appointments available. And I know people who've been turned away, even with an appointment. And I know people who've sort of done a walk up and gotten it. So it really is a free for all. Just,
and I'm sorry that you have to experience it that way.
I would not recommend this. That's what I say to my friends back home who are saying, "Oh, it's so impossible in Baltimore," And I said, "Well, it's not so easy here either." So
yeah. Yeah. So those are
Very
the
good.
sides of the spectrum. Either it's too strict by interpretation or not strict enough. And so again, even as you just said, even within the state, each county may be implementing differently. So again, that's what causes a lot of confusion. And I think again, it's regrettable that you have to experience that, and I'm sorry.
Yeah, I mean, the lack of a national policy that's really strict is amazing to me. Um, so I think there's sort of take-home lessons here, and then I want to talk a little bit about the university for a moment, since you're kind enough to join us. Um, the take-home lesson that I think I'm hearing from you is the vaccine is now becoming available. It's being handed out, at least in Maryland, by priority group. That you, as an expert, recommend that people take it, given the opportunity, and that there really aren't any significant reasons why not to take it unless there's a personal history of anaphylaxis to vaccines. Are those fair statements?
That's right. That's right.
Very good. So, I mean, that's the take home message I want to make sure people hear, because you're an expert, and everybody's sort of going out on the internet and reading what they read, and that can be a little dangerous sometimes.
Extremely dangerous. What's on the internet these days, and purporting themselves to be the truth. So in many different ways, in politics, in science, in other things.
All right. So we're going to stay away from the politics on this show, because Beth gets mad at me when I get political. So we're not going to do that. But I did want to put in a little word about the University of Maryland. You're nice enough to join us. You came to us through Dr. Stephen Davis, who's the chief of medicine over there. Wonderfully, wonderfully bright guy who has tremendous interest in the care of patients in Maryland, and in particularly in West Baltimore, and is really a leading light in healthcare in the state of Maryland. Tell us a little bit about your department and the other things you're working on.
So and I'll just echo that Dr. Davis is a terrific physician, very kind-hearted, and a really great scientist as well in his field. So he's an endocrinologist, and so really terrific. So I'm a faculty member of a center that's called the Center for Vaccine Development and Global Health. So it's a little bit self-explanatory, but developing vaccines, and we are a global health institute. But I'm an infectious disease trained physician. So again, what I'm trying to do is prevent infectious diseases and developing vaccines to prevent them in the first place. I'm not a therapeutics person. There are infectious disease physicians that are very good at therapeutic measures or even developing diagnostics. We have a large division of infectious disease within the Department of Medicine under Steve Davis. And so, we take care of a large number of HIV patients all throughout the tri-state area. We have a number of transplant patients, and because they're so immunocompromised, and so that they don't reject their critical organs that we've transplanted, they're susceptible to a lot of infections, and some of them are very weird infections. So we are, under, we are utilizing our specialty for that. We have a large cancer center here. So again, a lot of cancer patients can get some, so-called weird infections and other things. And the run-of-the-mill infections as well. And we man and staff a number of different hospitals.
So talk about for a minute, I know we're getting off the topic a little bit, and I'm showing my age. I remember the first HIV patient we saw. I was at George Washington at the time. It was in the mid-'80s, and it was a death sentence. Talk about HIV treatment today, because there's been such incredible progress there.
Yeah, absolutely. In the early days of HIV, even when we had therapeutics, it was just a single therapeutic that was very reactogenic, caused a lot of, symptoms. You had to have a handful of pills multiple times a day. It was, a difficult experience to say the least. And still people would, it wouldn't maintain the HIV very well. But then came along a number of HIV medications that then we started using all in combination. So this is, where we started putting together 2, 3 different types of therapeutics, HIVs together. And that's what really helped us to get a great control over HIV, such that we can make it so people have undetectable viruses in them and can maintain that, with, one pill that has all three of these different drugs in them as a single day pill. So the pill burden is so much better now. Instead of handfuls multiple times a day, it would be just one pill once a day. And that is enough to drive down the virus so that you have undetectable virus for the rest of your life. And basically people are living normal lives and dying of, plain old heart disease or whatever else that we might die of in older age. And so it's been tremendous progress over the decades, such that, again, HIV is not that death sentence anymore. We can't cure it, so people still have to take a daily medication, but we are trying to look for, a vaccine to cure it or to prevent it completely. We don't have a vaccine against it either. So again, HIV is still out there, but it is controllable, and it's not the critical thing that was, it was like in the 80s.
Yeah, pretty amazing stuff. So I really appreciate the update and what you all are doing over at the university, because it's pretty incredible. People don't realize that in Baltimore, we have two of the greatest healthcare institutions in the world. You hear about Hopkins a lot, but Maryland doesn't get its due. I mean, on an international basis, the university is a leading research institution around the world. So we really appreciate what you do. And Beth, do you have any other questions? And otherwise, we'll let Dr.
No, I'm just going to, I'll do our wrap up. I'm sure there are questions out there. And I just want to encourage, first of all, Dr. Chen, thank you. Thank you so much. This has been so helpful, so informative. And so I want to encourage all the people on this, our live show, to please tell your friends. This is a place now where correct information is possible. There's no fake news on this channel. And so please follow up, recommend this to your friends. Dr. Chen, you will have helped literally thousands of people in our community just by being here with us today. So thank you so much.
Well, it's been my pleasure.
I also want to let our audience know about an upcoming event for healthcare professionals. On January 25th at 6 p.m., the Associated is hosting internationally recognized medical expert, Dr. Susan Blumenthal. And she'll be talking about the future of health policy in America. Also join us again right here next Tuesday, January 19th, for another edition of The Upside. Scott will have magically reappeared by then, I'm quite sure. So, and in the meantime, continue to visit associated.org and jmoreliving.com for more information, for stories, for resources, and sign up for the weekly newsletter. And until we meet again, please stay safe. And if you have the opportunity, Dr. Chen's holding up his sign, get your vaccine.
Wonderful. Thank you, Dr. Chen.
Thank you so much.